Hello everyone, my name is Dr. Kjer, and today I'm going to give you a talk about afferent neuro-ophthalmology. We're going to go through anatomy, the retina, optic neuropathies, chiasmal disease, as well as retrochiasmal diseases. So the visual information gets from the eye to the back of the brain, first by reaching the eyeball, then to the optic nerve, then to the chiasm, then to the optic tracts, as well as the lateral geniculate nuclei, then the optic radiations, and then to the primary visual cortex. The higher visual cortex is the area which governs higher visual order processing. So here's an anatomic pathological view of the visual structures that we just discussed. One can see the right and left optic nerves over here. They cross here at the chiasm, and here's the left as well as the right optic tract. They eventually get to the lateral geniculate nucleus, which is the first synapse for the anterior visual pathway. And then here are these fan-like structures. And these are the optic radiations. Here's the temporal portion of the optic radiations, and this side is the parietal portion. And so here we get to the visual cortex, which is area 17 in the occipital lobe. And here are the higher areas of visual processing. So let's start talking about the retina. So the retina again is this film in the eye where visual information is first brought into the visual system. And the role of the neurologist is to make sure that there's not an optic neuropathy. And in retinal disorders, often there's no afferent papillary defect, but you will see fundus abnormalities in these patients. So in this example over here, this is where the fundus looks like in an individual with central retinal artery occlusion. And this is the cherry red spot. There is whitening and retinal edema as well. And the reason for this cherry red spot is that this is where there's no retinal ganglion cells, and one can actually see the circulation underneath. And here's an example of branch retinal artery occlusion, where just half of the retina is edematous and white. One can also see this branch retinal artery occlusion in Tay-Sachs syndrome, where there's a combination of this branch retinal artery occlusions, hearing loss, as well as an encephalopathy. A neurologist might also see retinal disorders in inherited diseases, such as the first category here, which would be the leukodystrophies, such as Tay-Sachs and Niemann-Pick syndrome, where one can see a cherry red spot. And it's not from the vascular occlusion, but this time it's from lipid accumulation in the retinal ganglion cells. And again here, one sees the underlying circulation in the macula where there's no retinal ganglion cells. Then retinal disorders can also be seen in von Hippel-Lindau syndrome. These are autosomal dominant. One can get retinal angiomas, cerebellar hemangioblastomas, as well as Kjer syndrome, which is a mitochondrial disorder. In this condition, one can have retinal degeneration and a chronic progressive external ophthalmoplegia and corneal conduction defects. In tuberous sclerosis, which is an autosomal dominant disorder, one can have retinal hamartomas, epilepsy, adenomas, as well as renal angiomyolipomas, cardiac rhabdomyomas, as well as ungual fibromas. And then lastly, we've got the spinocerebellar ataxia, or SCARS. And SCAR type 7 is an autosomal dominant condition and can present with retinal degeneration as well as a progressive ataxia. Okay, so let's move on to optic neuropathies. So the clinical features of optic neuropathies include acuity loss, color vision loss, visual field defects, as well as an afferent papillary defect. So let's talk about each of these ones individually. So we are interested in visual acuity loss as a presentation of optic neuropathies after the correction of refractor error has been performed. So one has to make sure that either glasses are used or there's a pinhole used to achieve the individual's best corrected visual acuity. And of course, we use the Snellen chart, ranging from 20/20 vision up until here where we've got 2800 vision. So color vision is tested typically with Ishihara plates. Here's a 42 as well as a 6. And when there is color vision loss out of proportion to visual acuity loss, that's a signal or a sign of an optic nerve problem. And here's an example of normal computerized visual fields. This is the visual field of the left eye with a subsequent blind spot, and here's a visual field of the right eye with its normal blind spot. And here's an example of what we call Goldman visual fields, where the circled areas refers to what the patient sees with a particular stimulus at a particular luminance. And this large circle here is for a large stimulus with a very bright luminance or light source. And then these smaller circles are for smaller stimuli which are dimmer light. And this is normal for this individual. So let's go over some visual field defects that can be seen in optic neuropathies. So A refers to a central scotoma, and this here is what the patient cannot see. B, this is called a centrocecal scotoma or a cecocentral scotoma, where the individual has a central defect connecting to the subsequent blind spot. And this is a Goldman visual field of the patient. And C here is an Humphrey visual field or computerized visual field demonstrating a superior altitudinal central scotoma. And that is a central defect, but it is just superiorly. D here is an inferior arcuate altitudinal scotoma emanating from the blind spot and extending inferiorly. Here's an example of a Goldman showing a superior altitudinal scotoma where the individual can't see superiorly, but they can see inferiorly. And this is an example of an infranasal step here in picture F on a computerized visual field. So these are all visual field abnormalities that can be seen in optic nerve disease. So one has to test the pupils in a patient with a suspected optic neuropathy, and if optic neuropathy is asymmetrical or unilateral, one will have an afferent papillary defect, also known as a Marcus gun pupil. So here's an example of a baseline of both pupils which are equal. This individual with an optic neuropathy on the left will have light shine into the right eye, and then both pupils will constrict. Then the light is brought onto the left side where the optic neuropathy is present, and both pupils will then get a little bit bigger. And that's because there's less light getting in from here to the midbrain. The pupils are still constricting on the left, but just much less compared to the right, and therefore it looks like it's dilating, but it's a relative dilatation, not a true dilation, and hence the name relative afferent papillary defect exists. So here's an example of a patient with an optic nerve problem on the left. Light is shown into the right eye or the good eye, and both pupils constrict nicely. And then light is shown into the bad eye or the left eye, and you can see both pupils constrict, but just much less compared to the normal eye, and it actually seems that they're getting larger. And again, this is an afferent papillary defect indicative of an optic neuropathy. So what are the causes of an optic neuropathy? Well, papilledema is an optic disc swelling due to elevation of intracranial pressure and can cause optic nerve abnormalities. Optic neuritis is an inflammatory condition of the optic nerves. Nonarteriticischemicoptic optic neuropathy is a vasculopathic disorder. Arteritic ischemic optic neuropathy is due to giant cell arteritis. One can also see inflammatory conditions, infectious conditions, optic nerve compression, neoplasms, inherited optic neuropathies, toxic nutritional optic neuropathies, as well as trauma and retinal mimics. So let's go over some of these. Okay, so I'm going to start with acute papilledema. Again, this is optic disc swelling due to elevated intracranial pressure. In this condition, you have obscuration of the retinal vessels at the disc margin. One cannot actually clearly see the disc margin. There are peripapillary hemorrhages. These white arrows represent all of the peripapillary hemorrhages. There's also associated venous distension. Acuity losses are uncommon, but visual field defects are very common. It's typically a late finding in patients with papilledema, so it takes about 2 to 3 weeks for visual loss to set in. But sometimes you can have fulminant papilledema that can cause much more or more acuter visual loss. Um, like I mentioned, these are all splinter hemorrhages in the fellow eye as well of an individual with optic disc swelling. And of course, one has to evaluate for intracranial mass lesions with neuroimaging, hydrocephalus, venous sinus thrombosis, edema, as well as pseudotumor, cerebri, or idiopathic intracranial hypertension, causing this papilledema. Now, in chronic papilledema, the hemorrhages have resolved and the optic nerve takes on this champagne cork appearance. Again, there's still some obscuration of the blood vessels as they are passing underneath the nerve fiber layer, which is still swollen. Now, of course, there's pseudopapilledema, and pseudopapilledema is an elevated optic disc that looks like it's swollen, but it's not really. And one of the more identifiable causes of pseudopapilledema is optic nerve drusen. And these are little calcifications. So as we can see here, there's a lumpy bumpy here, a lumpy bumpy here, as well as on this areas, we can see multiple lumpy bumpies. And in this instance here, they are the most visible form where they take on the form of these little yellow tapioca balls. Notice the retinal vessels that are not obscured, that can be seen, and this condition can be seen running in families. And if one is lucky enough to get a CT scan, one can definitely see calcifications on the optic nerve head. And these are, of course, a benign condition. So when there's an optic nerve swelling of unknown etiology and there's normal brain parenchyma, we call this pseudotumor cerebri. And if the patient didn't have any medications or any other reasons to have this, we call it idiopathic intracranial hypertension, or IIH. The clinical features of this condition include headache, papilledema, transient visual obscurations, which are seconds of visual loss related to the papilledema, pulsatile tinnitus, visual field constriction progression from peripheral to central visual loss, and one can also have a sixth nerve palsy as a false localizing sign. Risk factors for IIH include obesity, being female, and having a recent weight gain. Causes of secondary pseudotumor cerebri include tetracyclines, vitamin A derivatives, growth hormone, as well as withdrawal from chronic steroids. To make the diagnosis of idiopathic intracranial hypertension, one has to have a normal MR as well as MR venogram or CT videogram. Papilledema has to be present in most cases, and the lumbar puncture has to be done and demonstrate elevated opening pressures of greater than 250 millimeters in adults or 280 millimeters in children, as well as no evidence of meningitis or malignancies and neoplasm. Management include weight loss, acetazolamide, which has been shown to lead to improvement in visual fields in mild cases, shunting of our optic nerve sheath fenestrations, where there's either bad headaches for shunting or a progressive visual loss despite having medical treatment with optic nerve fenestration. One has to follow the patient with serial examinations and automated visual fields to detect progression. But most patients do extremely well with acetazolamide as well as weight loss. So Foster-Kennedy syndrome refers to a fundus abnormality with optic nerve swelling on the one side and contralateral optic nerve pallor on the opposite. So why does this occur? Well, when there's a subfrontal mass which is compressing on one of the optic nerves, it not allowing it to swell and then becoming atrophied. But this will result in an elevated intracranial pressure, where one will have then obviously papilledema in the opposite side. So optic neuritis is an optic neuropathy due to inflammation of the optic nerves. The clinical features include painful visual loss, where there are pain with eye movements. This occurs typically over 1 week. There's then subsequent recovery within 1 to 3 months and can be seen bilaterally in children and patients that present with neuromyelitis optica spectrum disorder, or NMOSD, where patients have simultaneous and sequential involvement of the optic nerves, as opposed to an optic neuritis that affects isolated one nerve at a time. 1/3 of cases in adulthood have mild disc swelling, and there are no hemorrhages or cotton wool spots. Here's an example of a patient with a fundus in a patient with an optic neuritis and mild disc swelling, also referred to as a papillitis. Patients with optic neuritis should undergo brain MRI to assess for the risk of progression to multiple sclerosis. If there are no white matter lesions, the risk is lower than if there are white matter lesions. IV steroids hasten the recovery of vision in optic neuritis, but it does not improve the final outcome. The NMO antibodies should be checked in atypical cases, such in patients with bilateral optic neuritis and patients with African descent, or there's no visual recovery after 1 month. The typical MRI in optic neuritis shows swelling of the optic nerve and enhancement of the what we refer to as the fat-sat axial imaging of the orbits. And then a patient with either MS or who is at risk of MS, there will also be periventricular white matter lesions. Now on follow-up, there's often the development of temporal pallor or diffuse disc pallor, and this is due to a dropout of a nerve fiber layer, which then represents retinal ganglion cells. And these are interrupted by an optic neuritis. So one way to follow up quantitatively is with OCT or optical coherence tomography. And in this instance, the red is the thin area. So over here in this black line, which this black line represents, it means that there's temporal thinning or temporal atrophy seen in this person if we perform the optical coherence tomography scan. So now let's talk about vascular disorders of the optic nerve. It's important to note that the central retinal artery, which is coming up here, supplies the retina, but does not supply the optic nerve head, which is actually supplied by the posterior ciliary arteries, which can be either the long or short division. Now, both the posterior ciliary artery as well as the central retinal artery are branches of the ophthalmic artery. So looking at the ischemic optic neuropathies, I'm first going to look at the non-arteritic ischemic optic neuropathy. Patients typically present with small crowded optic nerve with a small or absent cup. There is swelling in the involved side, but if you look at the fellow eye, the cup is often very small or absent. So this is an example here of a fundus with an ischemic optic neuropathy with disc swelling and vision loss. The vision loss is typically painless, it's acute, and it typically occurs in adults with other vasculopathic risk factors, such as diabetes, hypertension, and dyslipidemia. In addition to the crowded nerve, who have a smaller cup, patients sometimes have a history of nocturnal hypertension due to taking their blood pressure medications before they go to sleep. The recurrence in the same eye is rare, but there is a 30% lifetime risk in the fellow eye. So just a little bit more of ischemic optic neuropathies, as one can also see splinter hemorrhages. Here's an example of disc swelling due to an ischemic optic neuropathy, and we typically think of this as being a small vessel vasculopathy of the optic nerve. And that's why there's often an altitudinal defect because of the loss of blood supply in the optic nerve, which is divided into that superior and inferior distributions mediated by the long and short ciliary nerve, blood vessels. Typically, the visual defects are stable with minimal improvement over time. In inflammatory optic neuropathies, in addition to the regular garden variety optic neuritis, one can also have underlying other disorders causing inflammatory optic neuropathies, such as sarcoidosis, lupus, Sjogren's, and sometimes it can be even associated with eye inflammation, such as uveitis, to indicate that the patient has some form of systemic inflammatory disorder. Here's an example of an inflammatory optic neuropathy due to a systemic disorder. And on this coronal image, you can see the swelling and enhancement of this optic nerve. In ischemic optic neuropathy due to temporal arteritis or giant cell arteritis, the vision loss occurs again in patients who are older, but often there's a Caucasian predilection. Patients might have systemic symptoms such as scalp tenderness, myalgia, or also known as polymyalgia rheumatica, jaw claudication, and fevers. The disc swelling is a little bit different from the regular ischemic optic neuropathies because it's typically chalky white, and there can also be coexisting areas of retinal ischemia manifested as cotton wool spots, as you can see here. The diagnosis is made by a high sedimentation rate or ESR combined by a high CRP. Fluorescence angiography can now show deficits of the colloidal circulation, as well as a temporal artery biopsy should be performed within the first week to demonstrate inflammation of the blood vessels. Patients should receive prompt steroids. We prefer IV steroids as we believe that steroids prevent collateral eye involvement, and this is an emergency that steroids should be given right away. So there are also infectious causes of optic neuropathies, sometimes combined with retinal abnormalities, and this is called Neuroretinitis, where there's an inflammation both of the optic nerve and the retina, and when fluid in the macula precipitates, one gets these lipid stars, and this is a classical picture of neuroretinitis. The most identifiable causes of neuroretinitis is cat scratch disease due to Bartonella, but one can also have it in clinical scenarios, like with syphilis and opportunistic infections like TB, which is commonly seen in our country. In compressive optic neuropathies, one can also develop vision loss due to a mass pushing on top of the optic nerve. And in this case, this is an example of an individual who has an optic nerve meningioma with shunt vessels and disc swelling as well as vision loss. We can also have this type of compression with cellular masses like in meningiomas. Here's an example of a fibrous dysplasia where there's bony overgrowth and obliteration of the optic canal. Here's an example of neoplasms in the optic nerve. Here we have enlargement of the optic nerve on the left, but a little bit on the right as well. The most classical form of this is juvenile pellucitic astrocytomas, which is typically a grade 1 a variant of malignancies, also the so-called optic nerve gliomas. They can then be grade 4 examples, such as glioblastoma multiforme, but also lymphoma, leukemia, as well as metastases can invade the optic nerve and cause vision loss, as well as optic nerve enlargement. Other tumor-related causes of vision loss include radiation-induced optic neuropathy, as well as a paraneoplastic form of optic neuropathy, the so-called anti-CRMP5 variant. Leber's hereditary optic neuropathy is a mitochondrial optic nerve disorder. This is due to a mutation in the position 11778, and Leber's displays a maternal inheritance form because it's a mitochondrial disorder. There's a 9:1 male predominance. The typical age of presentation is 20 to 30, and there's painless sequential visual loss. That is that one eye is followed weeks later by involvement in the other eye, and there's often hyperemia with a so-called pseudodisc swelling effect of the optic nerve head, and this can be seen with associated capillary telangiectasias. Kjer's dominant optic atrophy is another genetic disorder. Patients typically have severe temporal pallor and scooping of the optic nerves. This is due to a mutation in the OPA gene, and there's a presentation is typically bilateral in childhood with a slow onset and stable course over time. In toxic nutritional disorders, there's often a cecocentral scotoma and disc pallor. The vision loss is painless, insidious, and symmetrical. Causes include tobacco, alcohol, B12 deficiency, ethambutol, as well as amiodarone toxicity. In traumatic optic neuropathy, one can have either direct or indirect trauma to the optic nerve. Here's an example of direct trauma to the optic nerve, where a BB gun shot was shot right into the optic nerve, and obviously this would be associated with vision loss. The indirect form occurs when there's a severe blow to the head, and then the optic nerve becomes injured within the optic canal. Optic nerve hypoplasia is a congenital optic neuropathy, and the optic nerve is small in diameter and there's surrounding visible sclera. This is the so-called double ring sign. One has to evaluate for other associated central nerve system abnormalities. In the so-called septo-optic dysplasia syndrome or de Morsier syndrome, one can have the absence of a septum pellucidum. As in this coronal image here, the patients can also have endocrine abnormalities and cortical heterotropia, which predispose to seizures and epilepsy. So there's a form of optic nerve hyperplasia, which affects the superior portion of the disc, and this is associated with maternal diabetes. Okay, so let's move on to chiasmal diseases. So the anatomy of the chiasm is in such a way that the optic nerve is actually arising at 45-degree angle coming out of the bone here. And here's a chiasm, which sits above the pituitary gland against the stalk. And so it's easy to imagine that any pituitary growth, when enlarging into the supracellular space, can interfere with either the optic nerve or the chiasm. When the so-called chiasm is prefixed, one can have an optic tract abnormality as the pituitary enlarges. And the so-called post-fixed chiasm, when the pituitary enlarges, one might predispose to an optic neuropathy. As you can see here is a relationship of the circle of Willis with the chiasm in the optic nerve. Notice that the anterior portion of the circle of Willis is above the optic nerve, and the posterior portion of the circle of Willis is below the optic tracts as well as the chiasm. And here's a cutaway view of the fibers starting in the optic nerve, then going into the chiasm, and then going back to the optic nerve tracts. And notice that there's more crossing of nasal fibers and there are more crossed than uncrossed fibers. So the nasal fibers are crossing much more than those ones running in the temporal distribution. Now, chiasmal field defects typically occur due to involvement of the crossing of the nasal fibers. So compression typically causes the classical bitemporal hemianopsia, where one has a loss of vision on the outside of both visual fields. And that's because the nasal fibers subserve as the temporal field information. And where one has a lesion here at number 3, there's going to be interference with the temporal field information on both sides. Classical causes include a pituitary adenoma, cranial pharyngiomas, meningiomas, as well as aneurysms. Now, if there's inferior compression, such as with a pituitary macroadenoma, one can develop a bitemporal hemianopsia just in the superior portions of the visual field. If there's compression of this chiasm from above, such as the cranial pharyngioma arising from the third ventricle, one can have a bitemporal hemianopsias as well, which are predominantly inferiorly, as in this case here, due to that large cranial pharyngioma compressing on the superior portion of the optic chiasm. Now, a very characteristic visual field defect that can occur in the chiasm is due to interference of this area here, and the proximal optic nerve, where there is crossing of the nasal fibers which subserve the superior temporal field information, and this is called Willebrand's knee. And if one has a lesion here at number 2, one will have a complete visual loss due to an optic neuropathy on the right side, but in the other eye, not in the right eye, but on the left eye, there will be a superior temporal portion of visual field loss. And this is the classical junctional scotoma. And this side of the lesion is dictated by the optic neuropathy. So junctional scotomas is an optic neuropathy field defect plus a contralateral superior temporal field defect. Okay, so let's move on to retrochiasmal diseases. And so the next region going back after the chiasm is the optic tract here at number 5. And if you have a complete lesion of the optic tract, you would of course have a homonymous hemianopsia on the other side. That is vision loss on the other side in both eyes, but often the optic tract lesions are compressive. So a visual field deficit is incomplete, and one would typically have an incongruous visual field loss, where the visual field loss is different in both eyes. The reason for that is because of the nasal fibers that contain a lot more fibers. Therefore, that's more severely affected on the temporal visual fields compared to the other side. And that is again a homonymous hemianopsia because it's in the same side on both eyes. And here's a schematic example of an incongruent visual field due to a tract lesion. And here's a Humphrey visual field from the true life example of such a field defect. An afferent papillary defect on the opposite side of the tract lesion can occur because of this asymmetry of visual field loss that's subserved by the large bundle of fibers carried by that nasal portion of the fibers coming over. Now let's talk about visual field defects related to the lateral geniculate nucleus. Now the lateral geniculate is shaped like a hat. It has a lateral portion and it has a medial portion as well as a hilum. So the lateral portion subserves the visual field information superiorly. The medial portion subserves the visual field inferiorly, and the hilum is here in between. Now the anterior choroidal circulation feeds the lateral as well as the medial portions of the geniculate. The posterior choroidal artery subserves the hilum. So from a vascular process to the anterior choroidal artery, one can lose sectoral portions of the visual field in an homonymous fashion. Okay, so let's move back to the optic radiations. And if you recall from the pathological example that I showed in the beginning of the presentation, I showed you the optic radiations that can fan forward into the temporal lobes. And that's the so-called Meyer's loop. And when one has a lesion in Meyer's loop, such as with neurosurgery, you can lose your visual field information above in the superior portion of the visual fields in both eyes, as shown here. As in this example, it formed this was from a right temporal lobe lesion, causing a pie in the sky defect here in the upper left side in both eyes. And if the lesions is in the optic radiations, the visual field defect will be below, inferiorly. Here's an example of an inferior homonymous field defect in both eyes due to a left optic radiation lesion. And finally, let's get back to the primary visual cortex. And this is the so-called calcarine cortex. And here you have that upper bank, and here you also have that lower bank. And if you notice that the foveal representation occurs here in the posterior part. And there is also a cortical magnification factor, such that the foveal representation takes up a large amount of visual cortex. So that's here. So here you can see 2.5 degrees, 5 degrees, 10 degrees, 20 degrees, and so on. And this is taking over much of the primary visual cortex. There's also a contralateral monocular crescent in the anterior occipital cortex, and that is the portion of visual field which is temporal in the one eye only, as observed anteriorly in the contralateral occipital lobe. So the blood supply from the occipital lobe is primary from the posterior cerebral artery. Here you have the calcarine artery in the occipital lobe, but there can also be collateral circulation from the middle cerebral artery coming over here. So then after visual information reaches this area V1 in the cortex, it gets processed into its higher cortical regions, passing through V2 and then V5 and ending up in MST. These are the so-called dorsal or wear pathway. And some visual information goes inferiorly into the ventral or what pathway through V2, V4, and then the subsequent face and object recognition areas. Those are represented by the LO, FFA, as well as PPA. But for more information on this, please look at that higher mental functioning lecture that I had on day 1. And with that, we conclude the topic for afferent neuro-ophthalmology. Thank you for listening.